Good evening, everyone. Thank you so much for joining our Integrity Implant System Surgeon webinar. We are thrilled to have our esteemed faculty on hand to go through not only some cases, but some MRI results, as well as some Q&A after the fact. Just wanted to let everybody know that we at Anika continue to hit major milestones with the Integrity Implant. We are just shy of 1 year of full market release, and we are already north of 1,000 cases since inception, which is exciting. We are adding new users every single month, which is exciting, and we're on trajectory to more than double the procedures that we completed last year, which is very exciting. Our Integrity Implant is based off of our HIAF technology. That's really our platform technology, and we're going to use that to drive further innovation within Anika. And additionally, just so you're aware, later this year, we are going to be coming out with some additional sizes for Integrity, which will be more applicable to some of the larger tendons that you see on a daily basis. Again, thank you so much to all of our reps who are out there pounding the pavement, pushing the message of integrity. And thank you so much to the surgeons that are joining tonight to learn more about this exciting product as we all continue to drive the success of Integrity. Real quick, let me just go ahead and go through our agenda. In just a moment, I'm going to turn it over to Dr. Chris Baker to present his MRI findings, and then as promised, we will have a Q&A with our panelists at the end. Joining us tonight, our esteemed faculty, we have Dr. Christopher Baker from the Florida Orthopedic Institute. He will be the main star of the show, sharing off his recent clinical results. We also have Timothy Codd, the other designing surgeon of Integrity from the University of Maryland. He's going to be serving as moderator today. We have Dr. Scott Sigmund from Orthopedic Surgical Associates. Many of you know, follow the Fro. I'll just throw that out there for you. He has had some excellent success with Integrity thus far. And last but not least, we have Dr. Sean Kelly from Colorado Orthopedic Specialists. He has been an avid user of Integrity, not only for rotator cuff, but other anatomical regions as well. So with that, again, thank you so much for joining. This is going to be an exciting webinar. Dr. Baker, I turn it over to you.
All right, thank you. All right, so thanks for the introduction, Adam. My name is Chris Baker. I'm from Tampa, Florida, and I was one of the designers with this, just working on the instrumentation and the implant itself. So I'm gonna give you kind of my experience with this and what we've learned over the past year and a half of the pre-market study and then the last year of post-market release. I'm at the Florida Orthopedic Institute in Tampa, Florida. I work with the residents and fellows at USF as well. And so research has become a part of what we do here. A bit of a disclosure, I am very conflicted here. I'm a speaker consultant. I receive royalties and research funding for this project. So just full transparency here. When we're looking at rotator cuff repairs, improving outcomes is our main goal. And over the last 20 to 30 years, the goal has really been working on the procedure itself. So we've transitioned from open repair to arthroscopic repairs. And those pioneers in arthroscopic surgery developed the instrumentation and the things we need to do this in an arthroscopic manner, from visualization, manipulation, and suture passing. We then worked on repair constructs, going from those open transosseous bone tunnel repairs to single and double row repairs, and then eventually to transosseous equivalent repairs. We then worked on improving our implants to get better, absorbable, smaller, in different ways to make things strong and essentially everlasting. So we're really to the point now that most repairs can be performed arthroscopically, and most rotator cuffs that we see are repairable. The problem is what do we do after we repair? What do we do to measure our success? We can measure our success both clinically as well as radiographically with structural healing. When we look at clinical success and we value patient satisfaction and function, we're pretty darn good at rotator cuff repairs. Patients are happy. 90% satisfaction rates, you can find whatever paper you want, and you'll see about the same results. We improve patients' pain, we improve their function, and we improve their quality of life. The problem is, in that 30-year history, converting from open to rotator cuff repairs to arthroscopic rotator cuff repairs, those clinical successes are really pretty static. So we're not really seeing a lot of difference in patient-reported outcome measures. Well, what about structural healing? We got better implants, we got better techniques. If you look at most reported outcomes out there, healing rates range from anywhere from 20 to 95% improvement in healing rates. And that depends on the patient's imaging modality, tear factors, patient comorbidities, all those types of things. So you may have one paper that puts out a 20% healing rate, the other is 95, depending on the patient and the factors. We do know, however, that patients that heal do better. Unfortunately, again, if you compare this to arthroscopic versus open repairs, we're really pretty static over this same 30-year or plus experience. So when we're trying to obtain this now, our outcomes today and our goals of improving rotator cuff repair are not so much on the technique. It's the success. It's the biology and strength and trying to improve that. When I got into training and got out of training, stem cells and PRP were all the rage. We thought for sure we would squirt some special cells in there and grow rotator cuffs. Unfortunately, that's not really happened. And really, over the last, say 5 to 10 years, we've really seen a blast off and graft augmentations, and this is probably going to be the way that we can improve our outcomes. When we look at graft augmentation, the original tried and true is the rotator cuff repair with a dermal allograft augmentation. So we get this large repair. We try to perform this in a low tension setting. We place a bunch of extra sutures here, and then we'll slide our dermal graft in. We'll then crisscross our sutures, extend our footprint, and hopefully allow some form of a soft tissue washer to prevent failure. I did this for many years. I had some success with it. I definitely think my patients did better, but boy, is it a tough add-on at the end of a tough case. So after you've done your releases, you've done your repair, now you add another 30 plus minutes to get your graft in here if you even have visualization. So you have an expensive process that's difficult to do and hard to apply to all comers. So what is happening out in the market now? Dermal graft is still alive. Arthrex is still working on this process. They really pushed this graftment option. We're still using multiple anchors and sutures. We're now trying to find quicker ways to get it done arthroscopically, but we haven't really proven that we can do this through the scope. Still quite difficult. Results are pending, and we'll see where it goes. So many folks have turned to the xenograft option. So the number one implant out there is very clearly the Regeniten option. They have a very slick instrumentation process that makes this easy. The problem is probably twofold. One, we're dealing with bovine collagen, so we're dealing with collagen that is a xenograft in nature, and we're dealing with something that doesn't have a lot of strength at time zero. Another market competitor out there is Tapestry, another bovine type 1 collagen implant. The instrumentation not quite as slick, again, no time zero strength. So the options for this bovine collagen to improve time zero strength is the BioBrace, the PLLA addition to the bovine collagen. The difficulty here, again, no slick instrumentation. So we have bovine collagen for all three of these implants. Some have better instrumentation, some don't. Some are weaker, some are stronger, but we don't really hit the sweet spot of strength biology and ease of implantation. So then there's other market options out there. Rhodium, the synthetic graft. This is meant to be placed at the enthesis between the tendon and the bone junction. Again, not addressing the full complement of the rotator cuff on the dorsal side, but on the tendon bone junction, something that has to be placed in slid down sutures. And the verdict is out about whether that will help much. Then there's those fiscally responsive surgeons who are trying to use local graft tissue from the patient. They take the biceps tenodesis, they perform a tenotomy, they take some of that proximal biceps tendon, smash it down, and place it over top of the cuff. Unfortunately, it's very difficult to do. Not much data out there, but something else to kind of ponder. So what we've come up with in Integrity is a hyaluronic acid-based graft. And this graft is something that is a combination of hyaluronic acid and polyethylene to allow strength to the construct. So what we're trying to do is combine biology with strength of the polyethylene in a sleek arthroscopic design. The material is 80% HYAF, which is a hyaluronic acid derivative, and 20% polyethylene. And then it's woven into a knitted structure to allow increased tensile and shear strength, tear resistance, and suture retention. The blue lines are simply to allow you for orientation and knowledge of the end of the graft. The real thing here that is great is that Anika has found a way to modify the liquid version of hyaluronic acid. They can turn this into fibers, membranes, granules. The non-woven form on the bottom left here is the HYAF. This has been utilized for 20 years in the European Union for chondral lesions in the ankle, hip, and knee, and has really tried and true results. We've now progressed to this knitted progression on the right. So what do we do to kind of bring this to market? The FDA approval process, you got to bring it to the market leader. We just talked earlier that is the Regeniten. This is kind of a look at the lock stitch construction of our implant, which is going to be that combination of the hyaluronic acid with the polyethylene. If you look at the macro structure on the top portion of these images, you can see the organized fashion on the left, and you go into the scanning electron micrographs, you can see this nice woven structure that gives it strength. Whereas you look at the Regeniten, it's really just kind of disorganized, dehydrated collagen that's been removed of as much foreign material as possible. So we look at these materials first in a wet environment. We just kind of test their biomechanical strength. We know that once these things become wet, they act differently. So that's what we felt was important to test. And when we look at tensile strength over Regeniten, we have to see a 40% improvement in tensile strength. We also see a 3-time improvement in suture retention and a 3-time improvement in tear resistance. So biomechanically in a wet environment, we're definitely onto something. So then we look at the biology of this. This is an ovine model and a sheep model where we make incisions into the infraspinatus tendon. We then repair the implants over top of the rotator cuff, and we'll come back later for imaging and harvesting of the specimens. When we look at the 6-week imaging, and hopefully you guys can see my cursor here, we have Integrity on the left at low power and at high power. And what you have is the infraspinatus tendon here in this kind of lighter pink area. The purple is the implant itself. And after 6 weeks, we already see new tendon-like tissue forming both above the implant as well as at the implant tendon junction. And if you go to the high power fields, you can see this natural healing response of the invagination of the patient's normal healing response, resorbing these HA molecules and laying down its new tendon-like tissue. When we look at the same predicate material with Regeniten, we see the implant laid on top of the infraspinatus tendon, but not a lot of interaction between the tendon implant or above the implant itself. And as we look at the more high power fields, we see a little bit more lymphocytic activity, more heterogeneous kind of appearance to it, and less organization of the reorganization of the implant. So then we move to the 12-week time frame. We're going to see a significant improvement in this thickness of the tendon-like tissue between the implant and the native tendon. And then we also see a high layer of a new tendon-like tissue on top of the implant. And most importantly, we're seeing this implant being broken down and replaced. So if you look at the high level, high power magnified views, you're seeing this tendon-like tissue really just taking over the entirety of the implant. And again, if we look at the Regeniten at that 12-week mark, we basically see the material resting on top of the tendon without a whole lot going on. On the high power fields, we're seeing a lot more lymphocytic activity, which we're trying to avoid in this healing response. Finally, at that 27 or 26-week time frame, we're now seeing nearly the entirety of the material is gone from the Integrity. You're seeing simply just little polyethylene portions that are remaining here, just like you would see if you had a suture anchor repair. And then you have this beautiful tendon-like tissue that is over top of your tendon. And again, in the high power view, you're seeing basically all the hyaluronic acid material is gone. Unfortunately, again, in that Regeniten group, you're really just seeing that Regeniten implant just resting on top of the tendon. Now, orthopedic surgeons do a little bit better. So I like the tetrachrome stain. We do better with color. Remember, this implant has no collagen. It's hyaluronic acid and polyethylene. So this is the implant. You can see the woven polyethylene within it. And again, at 6 weeks, you can already see the blue line is the new tendon-like tissue. And you'll see that same layer on top of the implant as well. As we progress to 12 weeks, you can see this really thickened layer that is healing between the implant and the tendon, and then another layer on top, and you're seeing resorption of the entirety of the graft. And then by 26 weeks, you see this just huge area of new tendon-like tissue that is ingrown into our tendon and resorbing our implant. Whereas the Regeniten is entirely collagen, so that'll be blue, and we're going to follow that through time, and it basically stays about the same. We don't really see much change above or below, and we don't really see a whole lot of remodeling going on. So this was our preclinical study showing safety and efficacy in an animal model, and then we'll have to progress to the human model. Now, the beauty of what we tried to do is not only did we want to increase the biology and the strength, but we wanted to make this easy. We wanted to reduce the number of steps. We wanted to make this reproducible. So this is our tendon staple inserter. And what we have done is we've placed our peak staple in position and then placed our implant in it. So it's going to be all one step that we place our implant. And the most common question I get is how do you get the implant deployed? And this is my trick. The wheel itself will come parallel to your inserter device. I like to fold it back nearly 90 degrees. I actually do a little bit more aggressive even than this. But that's my preparation for when I do my insertion. This can be done either using hard or soft cannulas. Most people in the country do beach chair and hard cannulas. I'm going to try to convince you to try these soft cannulas. I'm a lateral position guy, but this can be applied to both positions. If you use soft cannulas, I recommend a 12 millimeter wide cannula, and I'll go from 3 to 4 centimeters in length based on the patient's size. This deployment skid will open up those channels that block the water extravasation, so that'll open it up while you place the implant in. So one of the beauties of what we've done with this is we've tried to go from a lateral first technique. So the implant will actually be stapled to the lateral tuberosity first. We'll then deploy it medially. And one of the beauties of this is that if you want, and you only have one portal, so if you're doing, let's say, a partial thickness rotator cuff repair, you don't have to create multiple portals to put the implant in. So this is a patient that has a high-grade partial thickness articular sided tear, and we're going to do an onlay repair only. We will not be performing any other procedures to the rotator cuff. We'll only use that lateral portal that I did a subacromial decompression with. So this is a real live video. I simply sped it up just a little bit for the interest of time. So I'll place my metal anchor or my metal dilator in. I'll fold the graft back on that wheel just to get it through the diaphragms there. Emily, my PA, is then going to impact it into the lateral tuberosity, all in one step. Once it's in, I'm simply going to remove that metal dilator. I'm going to pull back on the rubber dam of this, and then with one slide, I'm pushing that graft out. Now, because it's fixed already to the lateral tuberosity, I can simply remove the inserter and then work through that same portal. And because I have a high-grade articular sided injury, I'm trying to take tension off that tendon and try to thicken the tendon above it. And so what I'm going to do is start lateral. I'm going to go from posterior to anterior. And as you get used to this implant, you'll find you can really move it, you can tug on it. And as you get more comfortable, you'll probably become closer and closer and closer to the edges. And that's kind of what I've found over my series of patients over the last year and a half. So what you'll see is I'm taking the inserter device and I'm just stretching it a little bit. I'm letting my PA get her stuff in and out. You'll see that I'm trying to hit the edges of this. I'm easily at probably 60 degrees here. I have yet to have any issues with these things catching or going in. Other implants have difficulty really deploying the tacks themselves and getting them to stay. These have little anchors that catch at different angles and different depths that will prevent the pull out of the anchor as you do it. So again, I'm just stretching this tendon or this implant over the tendon. I'm hoping to take off a little bit of the stress to the injured tissue below it, and then we'll thicken it just like we saw in those animal studies. Also, this can be done in a two-portal technique, more like most implants are done. This is a patient here that's had a full thickness retracted tear. We already have our lateral acromial portal. So what I'm going to do is place the soft tissue tack in there. You can see that I already have my anchor in position. And then I'm going to do the same process, but instead of working from lateral to medial, I'm going to work from medial to lateral. It's my opinion that it's important for us to cover both the medial edge of the cuff as well as the tendon bone footprint, because we want to prevent those CHO type 2 tears medial to our tendon repair. And we also want to extend our footprint and get normal tendon bone junction. So what you'll see here, that medial tack is in position. I place my metal skid in position. I'll then fold the graft back over the wheel, and then I'll slide it down into the joint. Once we can see it, again, Emily, my PA, is going to impact this right between my lateral row. I'll actually place my anchor right at the tendon bone junction. I'll remove the metal part. I'll pull back on the rubber dam, and then I'm going to get my hand in the right position eventually, and I deploy it. So once it's deployed now, it's held in position. I'll use that medial acromial anchor now to just tack it down medial to my medial row repair. And now I'm off to the races. So I'm going to remove now the wheel. I'm going to remove the inserter handle. And then we're going to go from medial to lateral. So again, I'm stretching the implant medial to lateral, anterior to posterior, trying to offload that deeper tissue that's been repaired. Again, we're probably at about 45-degree angle here, not too bad. One thing I like is that both the lateral peak anchor as well as the medial PLGA tacks can both be reloaded. So Emily's about to show you here as I place my my fifth anchor in 1 second. So this is my fourth. My typical construct is 3 anterior, 3 posterior, and 1 in the middle, just because I like it to be stretched. But what she'll do here is she'll place this down, and I don't really like the depth of it. I want it to be a little bit deeper. So as she pulls it out, I don't like it. I ask her to put it back in. You can simply rethread it, and you can do this both on the peak side as well as on the PLGA sides and get it to the depth that you want. So very easy to do. This is reproducible. I'm under 5 minutes pretty much on all of these implants nowadays. So the Integrity experience so far, like Adam has alluded to, we started our initial pre-trial launching in this November of 23. So I'm just about a year and a half in on this. I've done 67 cases. Over the past year of our formal release, we've had over 1,000 cases performed by over 200 surgeons with no adverse events reported. So what we wanted to do was give our doctors and our reps out there just some information, right? So when you're doing new things, doctors have questions. We wanted to follow up on a short-term study just to get something out that we could show what these things look like. And what is important for me to show what MRIs look like at both 3 months and 6 months. I've done every graft out there. When people are trying new things and you have patients that have pain or stiffness or something like that, people get a little bit worked up. You get MRIs and people get a little bit excited about what they see. So we wanted to give, number one, outcome and safety, but we also wanted to give doctors kind of an idea of what to expect of what normal postoperative imaging might be. We also wanted to show that this works for both onlay partial repairs as well as augmented repairs. So we include both of those in this first small study. This is the group that worked with me on it, and we're currently submitting it for publication right now. So case number one is a patient that failed non-operative management for well over 6 months. She presented to us with 6 months of pain and came to us on second opinion. You can see on the left preoperative image here that she's got a pretty aggressive bone spur with a very bad tendinosis, if not partial thickness intrasubstance tearing to the rotator cuff. And having failed conservative options, we gave her the option for an onlay repair. We performed a subacromial decompression. She did have a small upper border subscap repair, which I did perform with a single knotless anchor, and then we placed the graft on top. You'll see a little bit sometimes in patients that have a little bit more reactivity to the peak anchor, but that does resolve over time. But you can see that clearly the implant incorporated very nicely. The real thing I wanted to show was more these bigger tears and show kind of how these things are acting in a larger environment. This is a 54-year-old gentleman, again, failed conservative management. I actually did not anticipate him having a very large tear. He failed a shot in therapy and came back after an MRI and had a massive tear retracted to the level of the glenoid. Luckily, when we got in the operating room, this was kind of a reverse L injury, so it actually easily mobilized to the lateral footprint. We performed our standard transosseous equivalent repair. We tried to do this as tension-free as possible, and then we augmented this with a graft. We then had him come back at 3 months, and this was kind of one of the first ones that we really got a good view on ultrasound. Those of you guys that are not familiar with ultrasound, I'll give you my best tutorial here. This is the greater tuberosity in a coronal plane. This is the humeral head. And then this is the deltoid fascia. So everything between this and the bone is our subacromial space. The beauty of this implant is that the polyethylene bounces off the ultrasound waves very nicely. So those of you guys that are comfortable using ultrasound, you can really easily see your graft. And everything between the graft and the greater tuberosity is our rotator cuff. So we have a beautiful rotator cuff here in the footprint. We know we're in the right place where I put the graft because you can see the graft there. And then you can see this exuberant healing response above the graft as well. And when you look at the MRI that we got within a week of the ultrasound, you see the exact same thing. This is my lateral staple, so you know that's the end of my graft. You can see that darker tissue is our rotator cuff, and you can see the soft anchor that we placed in here for the rotator cuff repair. And then you can see everything above this is our implant. And what's really cool that we didn't really anticipate, or I didn't at least, was that we start to see healing both beyond medial and lateral of our graft itself. So the graft probably ended somewhere in here, and it definitely ended where the anchor was here. So all of this is extra material that's kind of healing in with this reactive material. And what we see and what we were hoping for is that that material would then mature and incorporate to the tendon in over 6 months. That is what we're seeing. So this patient did great. He's got great range of motion, and he's now approaching a year and a half out doing wonderfully. Another patient with high-grade partial tear on the infra and a full thickness tear on the supra. Double row repair, graft applied, again, exuberant healing response at that 3-month mark that resolves and remodels over the 6-month mark with another great outcome. This patient had severe calcific tendonitis, just pockmarked throughout the rotator cuff itself. By the time I got done debriding it, we had created a fairly ugly bursal-sided injury. We simply placed our graft on top of this. Again, these are the things that I'm trying to make docs understand, that this is not necessarily a bad problem. This is certainly larger than the graft that we put in, but what we see is this exuberant healing response that will then remodel over time and then incorporate into our graft. So we're seeing this reproducibly, and we're seeing good results with it. Now, this is a little more interesting of a case. This is a case my partner sent to me. Nobody likes to send cuffs back to other doctors, but this was something that the doctor was concerned he didn't have a tool for. This is an MRI arthrogram. I have seen MRI arthrograms that have been put into the tendon, so I didn't fully suspect that this was real. So I repeated the MRI, and lo and behold, there was definitely a real myotendinous type injury, and we can see how deep it is. It's right at the level of the AC joint, very difficult to access from a graft standpoint. So we decided we would give it a whirl and see how it goes. On the intra-articular portion of the surgery, the articular capsule is intact and the deep cuff is intact. But the bursal side you can see is just kind of dog meat. It's been chewed up. and spit out. So we debride that partial thickness bursal-sided injury. You can see that there's still abutment of the acromion to it. So I performed the acromioplasty, which I do across the board on these. I want bleeding in biology. You can see the area that we debrided, and then we place the graft right over top of it. And for those of you guys that are familiar with putting these implants in, it's very hard to get anywhere near the AC joint. So you can see I'm not even to the AC joint medially, but I got as close as I could. But that was kind of my goal, was to get there. The beauty of this is that healing response. So what we see is that already I'm starting to see this exuberant healing response. That's our AC joint. We're not quite there yet, but it's already thickening at 3 months. And you can see on another cut that it is starting to extend to that area. And then again, the beautiful part of this 6 months remodeling, incorporation, and thickening of that tendon. And to keep me on this, having that anatomic land point of that medial clavicle, that's exactly where we were with our injury, where we wanted to repair, and that's where we ended up hitting the home run. This lady's a hairdresser. She's now got an issue on her other shoulder, and she is ecstatic. She was back to work full time at 3 months. Another patient, full thickness retracted tear, repair, good healing, exuberant response, 6 months incorporation. I've only got a few more. We only did our first 10 here. Full thickness, or excuse me, small, what I thought was gonna be partial thickness tear. As we got in there, the bursal side was partial thick or small, but the articular surface actually opened wide. It was about 3 centimeters deep on the articular side. So we placed 2 medial row anchors deep and then brought it down to 2 lateral rows, augmented with our graft. And again, exuberant healing response in that first 3 months. That's normal for me. And now we see that remodeling by 6 months. So very reproducible. Another full thickness injury. This one more big or more large on the bursal side, a little bit smaller on the articular side. Again, double row repair, graft in place, exuberant healing response at that 3 month mark. That will then resolve by that 6 months. And then I'm going to skip to the last one here that was really interesting. Another case where I've had a handful of these, and you may have seen these. This is basically just kind of, there's almost no real tissue here. And when you have patients like this that are functionally good as far as they have motion but have pain, I really worry about injections on these patients. I really worry about delayed management. I don't know other options to do other than to try grafts. So we went in, you can see on the articular surface, again, it almost looks like crab meat. My goal is to not mess with this stuff. I try to debride a little bit just so I can see, but I don't want the graft to fall, or the tissue to fall apart. We augment with our implant. And again, we see this exuberant healing response at that 3 months. And then we start to see incorporation and thickening and more kind of normal function of that tendon. And this patient was pain-free by the 3 month mark with full motion. So then we looked at our patients on these, and we looked at our ASES outcomes. We saw improvements that were significant from 40 to 76 plus. Our SANE was significant by the 3 month mark and the 6 month mark, both with significant improvements in doubling in patient-reported outcomes. And then when we looked at it, initially these were 10 patients that I thought were doing well. The goal was to show you what normal should look like. So I thought that these patients would be better than my normal patient population. So I asked our research staff to look at all of our patients that we implanted to this point. So the blue are the 10 patients that we performed the study on. The green are the all 50, I think there were 54 at the time of the study, all patients that I had done to date. And what we saw, which was kind of surprising, because partial thickness patients have pain, big cuff tears sometimes don't do great, but we definitely had steady improvements in all of these patients across all measures. Then we look at tendon thickness. This is taken from original BOCOR study of how they measured tendon thickness. You basically draw a parallel line at the footprint, and our pre-op average thickness of the tendon was 4.7. We then increased that thickness to 7.6, which has been shown to be at or better than the literature. Our PROMIS scores were improved, so we saw increased patient-reported health measures and no complications in our first 10 patients. We continue to try to improve on this. I'm really happy with how Anika has decided to approach this. They're supporting us from time zero. We're immediately collecting a multi-center prospective cohort study. We are not trying to get a bunch of sales out there and then say, let's see if it works. So we're already enrolling at 8 sites. We're looking to gain 150 patients in the next year or so, and then report these back to you on a larger scale with higher level of evidence. So, with the Integrity, what we're trying to do is we're trying to combine strength and biology, but we're also trying to do it in a manner that allows for us to be able to be performed in a rapid, efficient manner. So that's all I have there, Adam or Dr. Codd. and I will pass it to you guys.
Yes, thank you so much, Dr. Baker. Really appreciate you taking the time to share your case series as well as an overview of the Integrity Implant.